بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أنا دكتور محمد حسنين. يسعدني جدا أكون معكم في مؤتمر الجمعية South Egypt of Diabetes and Endocrinology Association. بشكر الدكتورة الأستاذة دكتورة لبنى على الدعوة الكريمة، وأتمنى أن تكونوا مستمتعين بالمؤتمر الناجح إن شاء الله. آسف إن أنا مش معاكم face to face، إن شاء الله في المستقبل أكون معاكم face to face. So let me move on to the topic of our lecture for today. It's beyond glycemic control, looking into a holistic approach. Of course, when we talk about diabetes, we need to do it from a clinical perspective. And I'm sure that this case scenario that you can see in front of you is a case scenario that you can all face every day in clinic. So let's go through it together. Ahmed, 46 years old, accountant, attends your busy clinic, diagnosed with diabetes, type 2 diabetes 4 years ago. He's got 4 children. He's diagnosed with hypertension 2 years ago and was started on a statin as well. His current HbA1c is 6.8%. Blood pressure is 134/78, LDL is 80, EGFR is within the normal range of 88, and ECR, albumin-creatinine ratio, is normal. His body mass index is 31. Like many people in Egypt, they smoke shisha on social level, maybe once or twice every week. He has no recent ECG. His current medication include metformin, 1,500 milligrams daily, atorvastatin 20 milligrams, and amlodipine 10 milligrams daily. So very straightforward case. Middle 40s person, diagnosed with diabetes not long ago, 4 years ago, hypertension as well. The HbA1c 6.8, blood pressure 134/78, normal kidney function, no recent ECG. Now, what would be your action plan? Would you assure him that he's well controlled? Would you advise him to lose weight and stop shisha? Would you assess for asymptomatic cardiovascular disease? Would you do the first two rather than just one of them, or the B and C? I'm not going to share the answer that I think is appropriate, but let's go through the process. Now, I think the point that we all need to think of nowadays is the cardiovascular risk category of every single individual who comes to us. And I would like to ask you again, what would you consider the cardiovascular risk of Ahmed? Is it very high, moderate, or low? Now, instead of us exercising our own impression, there is a process. Now, we have established this process in the Emirates Diabetes Society guidelines, where we look into, first, does the person have type 2 diabetes with cardiovascular disease or end organ damage? And end organ damage would be those with renal impairment, retinopathy, or nephropathy. So, in the absence of this, you start to look into the age, and Ahmed's age is less than 50. His diabetes duration is less than 10 years. So, and he has 2 risk factors, if you remember. He's hypertensive and a shisha smoker. So that put him into moderate risk. Again, the target organ damage, as I mentioned, renal impairment in the form of proteinuria or reduced EGFR below 60, left ventricular hypertrophy, or moderate retinopathy. So if this is present, then specific pharmacotherapy would be recommended. In the absence of this, then we start thinking of the factors that we just talked about: age, duration of diabetes, and then the presence of the various standard cardiovascular risk factors. And then eventually, of course, we need to address all the other options of efficacy of the drug, hypoglycemic risk, impact on weight, side effects, and very importantly as well, costs. Now, it's a big difference between people with type 2 diabetes versus people without type 2 diabetes. Here is all-cause mortality, and in orange or the lighter color is people with type 2 diabetes. And as you can see here, that the hazard ratio for all-cause mortality, or here for death, is much higher than those without type 2 diabetes, which is the darker brown color. And this is based on the data from the Swedish registry of over 2.2 million persons who took part, of them nearly 500,000 persons with type 2 diabetes. So clearly there's a big difference between both. Now I have looked into the admissions into patients coming to the cardiology ward in our Dubai hospital. And as you can see, in people with diabetes, they constitute a good proportion of those who are admitted with a previous history of CVD. Now, what is the cause of the problem? The majority of them have ischemic heart disease, but a sizable proportion, 30%, has congestive heart failure or heart failure in comparison with NDM, non-diabetes. So clearly, people with diabetes, even though they were not diagnosed previously as this group, many of them, when they are admitted, they have underlying ischemic heart disease or congestive heart failure. If they have established CVD, then they are the majority of the cause of admission in people into the cardiology ward. And that is not unusual. We have seen in Western society that in people admitted to the coronary care unit with acute coronary syndrome, they are 1/3 of the population. Perhaps in our community with the more risk factors, the prevalence is higher. And we should not forget that the presence of one cardiovascular or macrovascular condition means there's a likelihood of other vascular problems. So if your patient is admitted with cardiac problem, we need to do all our best to diagnose unmasked cerebrovascular or peripheral vascular disease. So here comes the question of, is the person asymptomatic, or actually they are symptomatic, but they are not doing enough activity to unmask the symptoms? When should we investigate, and how should we investigate? When I should refer to a cardiologist? Is there benefit of investigating through asymptomatic patients with diabetes? Many important questions that many of them do not have a straightforward answer. But certainly, when you look into the profile of our patients in the Middle East, and here is data from Abu Dhabi, you will find that many people have very high overlap between the hypertensive person with smoking, with prediabetes, whether they are males or females, regardless of the age. And of course, as we get older, the prevalence of these problems gets higher and higher and higher. This is data from Alexandria, my home city. And when we looked into the BMI of the cohort, which was nearly 10,000 persons in this cohort, the vast majority of the patients are with a BMI above the ideal. The ideal is up to 25. But as you can see, this is only 18% and 1% below that 18, below the BMI of 18. So let's assume it's 20% in total. So 80% of the cohort, 81% to be precise, have a BMI of over 25. So they are either overweight or obese. Now, to assess for the daily activity, for physical activity, unfortunately, many of us are not doing the necessary physical activity. I'm conscious, obviously, that this is a generalization. Many of our people are active, they walk to work, they do many physical activities at home, but in many cases, that's not the case. In Western society and Gulf society, there is helpers that do everything for the individuals. So the person does not exert themselves enough. I remember when I was in UK, when the weekend is over, and when I asked my Western friends, they have been active doing something. When I ask my Middle East friends, they talk about, we got together and we had a very nice meal in this restaurant or in this person's home. So there is a big difference. Even going to shop, there is big malls with car park, and even in many places, valet parking. And many of us spend our relaxation time smoking shisha. So moderate physical activity, which is defined as 10 minutes spent during daily activity, is done daily by only 17%. And the vast majority are doing it occasionally. When you go to slightly more intense physical activity, such as 10 minutes of playing, running or playing football, that is only done on a daily basis by 5% of our population. Again, in a bigger, wider range data from the MENA region, when we ask people to classify themselves, whether they're in inactive, low physical activity, moderate physical activity, or high physical activity, identical scenario. 4.4% who describe themselves as with high intensity physical activity. The vast majority, 2/3 of the patients, are either inactive or with low physical activity. So we need to start doing the simple things that we learned as in medical college. Symptoms and signs. We need to directly ask our patients questions about dyspnea, about reduced physical exercise tolerance, about fatigue and lethargy, orthopnea, nocturnal cough, wheeze, anorexia, and confusion and delirium in the elderly. And of course, we need to look for the signs that we all know about cardiac level of decompensation. Alternatively, we need to ask people of the equivalent of the metabolic task for the task. So light intensity is below 3, and this could be desk work or using a computer or walking slowly. Moderate intensity, which is considered as 3 to 6, such as working in the house, yoga session, tennis double, or sexual activity. And that's an interesting point, because perhaps many people are not engaged in any of this. So asking the person whether they are sexually active or not, and whether they get any chest tightness or shortness of breath, could be an indicator of their metabolic equivalent for their cardiac function. Because we know that if the person from the guidelines is diagnosed with such condition, with abnormality in their cardiovascular or renal system, then they will need to go on either an SGLT2 with evidence or a GLP-1 with evidence. Of course, SGLT2s are preferred in the presence of heart failure or in renal problems. But this is the problem that we are facing. Many of our patients are not. The meta-analysis have shown that SGLT2 inhibitors are quite important when it comes to hospitalization, for example. All of them would be helpful when it comes to hospitalization, but the other parameter, the cardiovascular protection, some of them would not be equally beneficial. The same with GLP-1 trials on composite MACE or cardiovascular death. The overall, there is benefit. Of course, some of the GLP-1 receptor agonists are neutral, others are much more helpful. So we need to choose, but the important thing is to be conscious of this. Now, when we look globally, we find that 5 years ago, this situation of prescribing these two classes was pretty low. 2.4% for GLP-1 receptor agonists and 1.4% in those on SGLT2 in the presence of cardiovascular disease. Now, obviously, I hope that this has changed. I have undertaken the same exercise into a subgroup analysis that is currently in a manuscript form in patients with CVD or CKD from a large survey that we did. And we find that we are talking about 10 to 11% of our population have these conditions. So we are not saying that all our patients are at risk or all of them have the condition. 10 to 11% have the condition. Many have multiple risks. But the interesting thing is when you look into prescribing, use of SGLT2 in those who do not have cardiovascular disease or CKD is 14%. Use in people with cardiovascular disease or CKD is lower at 12.5%. And the same would apply for the GLP-1. Much lower level in those without CVD or CKD, 2.6%, and it goes up to 4.9. So nevertheless, 4.9 of those who are at risk or indicated to have the treatment are on GLP-1 and 12.5 on SGLT2. So the vast majority are not. And clearly, inertia from our side as physician can be harmful for our patients. Now, I'd like to move on to beyond this important point. So my main point so far was to address the diagnosis of the cardiovascular risk specifically in a sedentary person who might not be exerting themselves enough to establish that they have symptoms or signs that would warrant an earlier diagnosis. And hence, it's the importance of digging deep for the signs or the symptoms. Hypertension is straightforward. I don't really care too much on whether you opt for a blood pressure of 140/80 or 130/80, 140/90 or 130/80, doesn't really matter. Agree on a target and work for it and try to ensure that your patients are doing so. And do not forget the importance of home blood pressure monitoring and also the role of education. Adherence to treatment is very much related to the person understanding the importance of hypertension control, the possible side effects, the contributing factors in their life, in their eating habits that would contribute to raising the blood pressure of this individual. Lipids, again, with diabetes is straightforward. There's not been very little change. The vast majority would need to be on a statin. Which statin? Well, depends on the risk factor of the individual. So it will vary between moderate to high. And again, here, the situation is easy. Moderate is all of these. High intensity is only two drugs with the two strengths that you can see in front of you. So not applying this would be not doing our patients enough justice. But part of the holistic approach is not just to think of, I prescribe the drug or what strength of the drug. I need to think of the other parameters. Smoking cessation, the right type of diet, and exercise are sometimes even more beneficial than prescribing a statin. A high-intensity statin, absolute risk reduction is 9, and the number needed to treat is 15. While smoking cessation is the absolute risk reduction is 9%, and the number needed to treat is 12. So really, we need to start thinking of a true holistic approach for all our patients, not just about the numerical figure of glycemic control, but the assessment of the cardiovascular for our patients, and indeed the right treatment and looking beyond the glycemic control, looking into the blood pressure, the lipid, the smoking, the right diet, and the right exercise. So unfortunately, even for the classic symptoms, for the classic drugs, antiplatelet drugs, beta blockers, ACE inhibitors, or statins, for people with cardiovascular disease in the community are low, even in people in high-income countries. So I urge all of you to start thinking of the right therapy for your patient, specifically if they have the underlying condition. So my take-home message to all of you is, we need, of course, to make sure that the patients with type 2 diabetes have a proper assessment for undiagnosed CVD or CKD. We need, of course, to have a systematic approach addressing all cardiovascular risk factors to minimize the diabetes-related complications. Of course, we need to think of measures of availability of such essential types of treatment. Some of them are very expensive, some of them are less expensive, and I'm delighted that there is even some generics that could be well prescribed. We need to improve measures for availability of these essential treatment and measures for treatment adherence, as well as physicians' inertia. These need to be adopted and encouraged because they can make a big difference. And finally, treatment should be started as early as possible. And with this, I would like to thank you all, and I leave you with this picture of the orchestra for diabetes and cardiovascular disease. It's not just about one drug, but it's a whole orchestra that working together will make a difference. Thank you all, and I hope that you enjoy your conference.